Hi, my name is Christopher Robertson, and I'd like to talk to you about our new paper, A Randomized Experiment of the Split Benefit Health Insurance Reform. This reform is really targeted at the runaway healthcare costs in the United States. And the traditional solution to healthcare spending in the United States has been patient cost sharing, copays and deductibles and other payments at the point of service. The problem with patient cost sharing is that we have to cap it in any given year to protect the purposes of health insurance, protecting patients from risk and guaranteeing their access to health care. But given that most health spending in the United States is by patients spending over $50,000 or more in a given year, the cap on cost sharing really undermines this mechanism of consumer-directed health insurance. An alternative solution we've developed is called the split benefit health insurance reform. The split benefit makes some of health insurance fungible rather than merely an in-kind health insurance benefit that's paid to the provider. So for example, suppose a patient is considering whether to consume a $100,000 off-label chemotherapy drug. The insurer would pay the patient $5,000, saying we cover the chemotherapy drug. The patient then decides whether she might like to spend the $5,000 on the chemotherapy drug, in which case the insurer would pay the $95,000 balance to guarantee the access to care. On the other hand, if the patient declines to consume the chemotherapy drug, she keeps the $5,000, it functions as an opportunity cost, and the insurer saves the $95,000. So in this paper, we decided to test the split benefit health insurance reform in a randomized vignette-based experiment with 1,800 human subjects that we recruited from an online population. We randomized them to either of two clinical scenarios, one an off-label cancer drug they're considering consuming, the other a prophylactic heart stent also being prescribed off-label, and we had a control condition where the patient was told that she's exhausted her annual cost-sharing obligation, the procedure is fully covered, would she like to consume it? We asked the mock patient to spend some time writing about how they feel and what they might be thinking and considering this very difficult decision. But then, in between subject design, we also offered some of the patients a split benefit payment. And we manipulated both the level of the payment, a $5,000 payment or a $15,000 payment, and we manipulated three different types of payments, whether prepaid or a rebate, or perhaps one that was limited in its fungibility to other healthcare expenses, similar to health savings account. The results were striking. We found that regardless of the type of split and regardless of the amount of split, there were dramatic reductions in intent to consume the off-label, highly expensive health care. We also asked patients, the mock patients, whether they would consider this as a reform to Medicare. And we found, regardless of political preferences and regardless of income levels, strong support for this as a reform to Medicare. And the reason why we think is that the split benefit is unique amongst healthcare reforms for promising to reduce healthcare spending while nonetheless preserving access to healthcare and the patient's own choices about whether to consume. Now, there are large ethical and legal questions remaining about the idea. We've addressed them in another paper. But for now, this paper suggests great potential for reducing healthcare spending. Thank you.